Custom versus prefabricated orthoses. Preform versus customized. What about over-the-counter versus digital scan and computer-generated orthoses? If you need a clear, definitive answer to which type of orthotic device is best when it comes to treating plantar heel pains, then welcome, you're in a roller coaster ride of a video. G'day, I'm Jedynak, international educator with health practitioner with over 30 years clinical experience treating MSK conditions of the lower limb. I help foot fixers, podiatrists, physios, chiros, osteopaths and other physical therapists take their skills and expertise to the next level so they can get the clinical breakthroughs their plantar heel pain patients expect. This 6th blog in a series of 8 is all about shortcutting your path through the conflicting research, complex issues and unpredictability that surrounds plantar heel pains. I'll take you step by step through the quagmire that surrounds this tricky condition to save you a heap of headaches. And as I've explained in the previous plantar heel pain blogs, I've had my fair share of headaches. I've gone from root theory to plantar fasciitis as a tensile traction injury caused by pes planus and excessive pronation. Now the evidence tells us that it's the enthesis causing the patients their grief. And then there are 47 potential causes of plantar heel pain, so accurate diagnosis can be pretty tricky. And without an accurate diagnosis, what chance do we foot fixers have of achieving excellent treatment outcomes? And last blog, we jumped into the unique process of assessing the plantar fascia without even touching the plantar fascia. We discussed anatomy trains using a bag of oranges. We also explored this most useful tool and how it can assess and treat your patients with plantar heel pains. If you missed that gangbuster blog, go back and have a look. We also had some awesome links to video demonstrations and how you can get yourself a tool, or be a tool. Maybe I'm the tool. Anyway, so moving right along. Today, we'll return to the conventional intervention of orthotic therapy in an unconventional way. As I mentioned in a previous blog, I believe that orthotic therapy has a place when it comes to treating plantar heel pains. But to be honest, I'm not an orthotic expert. My career began in the 1980s, which was a time when the running industry, sports shoes, orthotic prescription, it really took off. I mean, it was a perfect storm for sure. Treating overuse injuries with orthotic therapy gained considerable traction, and it was a massive boost for the podiatry profession. With this orthotic movement, the whole industry cranked out orthotic devices not only for overpronation conditions, whatever that means, but also for conditions such as hyperhidrosis, sweaty feet, ingrown toenails, venous disorders, jaw problems, headaches, and infertility. Unfortunately, this probably contributed to the abuse and overuse of orthotic therapy, which I'm sure has led to some ridicule of orthotic prescribers. One of my favourite orthotic stories comes from biomechanics research junkie Craig Payne. The story he highlighted was the speech and speech problems. He has speech problems. I need my orthotics. The story highlighted the speech and dancing improvements of a 13-year-old girl who'd had 4 strokes. 4 strokes in a 13-year-old girl? Well, that's what her referring Romanian doctor said. The girl progressed markedly, was basically cured after being prescribed orthoses. Whoa. I tell you, draw your own conclusions. Let's not labour the point about the outrageous claims of orthotic therapy, and let's have a look at what the evidence tells us. In particular, custom compared to prefabricated orthoses. Let's draw on the renowned orthotic expertise of Craig Payne, Simon Barthold, and Kevin Kirby. These gurus have way more expertise in this field, so I'm going to paraphrase their positions. Firstly, it's fair to say that a clear explanation of how orthotic devices actually work is still waiting in the wings. And I think it's also fair to say that there are a lot of podiatrists waiting with bated breath for that explanation. It's certainly not going to come from me, no surprise there. As you know, I'm a recovering root theory junkie who wishes he was Indiana Jones, but that's another story. Let's turn our attention to Craig Payne, who describes a study that he received funding for in the UK to randomly test 3 types of readily available over-the-counter devices. Now, as Craig says, he could flatten out each device with his little finger, so he described them, and I quote, "They were useless, theoretically. I wouldn't use them." There were 60 people in the study with plantar heel pain who were given these so-called useless over-the-counter devices. You know what happened? All of them got better, except 3. Now, there was a mean improvement of 40% in their symptoms at the 4-week review. Craig Payne's professional conclusion was, we can't ignore this result. We've got to try and work out what's going on. Then we move on to studies comparing prefabricated devices with custom devices. We run into the problem defining these categories. In particular, what is a custom device? Now let's take a close look at the study Karl Landorf did for his PhD, where he used prefabricated and custom orthoses. The problem with the custom devices is that even though they were fabricated using a custom plaster cast, the resulting orthoses were an average prescription. This means there were no individual customizations like heel raises for tight calves, no first ray cutout for functional hallux limitus, or no plantar fascia grooves for prominent plantar fascia bands. In other words, no individual customizations were used. I mean, were they truly custom devices? Doesn't look like it, does it? If those customizations were included, would it have made a difference? We just don't know for sure. Studies are telling us that different types of orthoses produce mixed results. Another study compared rear foot posture alignment and motion and kinematics. And the researchers looked for the correlation between range of motion, planar relationships, and symptom changes. The results? Some subjects got better, others didn't, and there was no correlation to any of the variables. Holy moly. If I quote some of Craig Payne's conclusions, there's a paradox with using orthotic therapy for treating overpronation. First, overpronation is not, or may be, a very small factor in causing MSK problems like plantar heel pain. An orthotic device may or may not be changing this overpronation, we just don't know for sure. But we do know that when we use an orthotic device, outcome studies show that people get better. Bože moj, a loda. Kevin Kirby has a number of lectures on the history, theory and evidence for orthotic therapy. His most recent presentation in Australia had some 62 studies quoted from which he concluded that orthoses alter location, magnitudes and temporal patterns of ground reaction forces on the plantar foot, alter both kinematics and kinetics of the foot and lower extremities, alter internal and external loading forces on structural components of the foot and lower extremity, improve balance, allow improved gait function and reduce pathological loading forces, allow more rapid healing of injured structures of the foot and lower extremity, and assist in the prevention of new injuries. If we move into the specific studies on orthotic therapy and plantar heel pain treatment, I suggest you investigate these. Does the use of orthoses improve self-reported pain and function measurements in patients with plantar fasciitis? A meta-analysis. The effect of different orthotic concepts as first-line treatment of plantar fasciitis. Foot orthoses for plantar heel pain. A systematic review and meta-analysis. I'll have the links for all of these articles in today's fabulous freebie, so you can review the literature for yourself. So, what can we conclude from this exploration of orthoses and plantar heel pains? As practitioners, should we use over-the-counter orthotics or customized orthotics? Let's just say that there's a grey area here. That's not necessarily a bad thing. Sometimes we health practitioners have to investigate the grey areas as best we can. And as we explored in a previous blog, being transparent with our patients about a treatment pathway and whether it's a trial or a test is usually the best way to proceed. Anyway, I encourage you to keep your ears and eyes open to the research as best you can. I hope what we explored here in this blog has at least given you an overview of the sorts of challenges that we face when it comes to orthotic therapy and plantar heel pains. Perhaps in the end, this is where you have made up your own mind by using your own clinical reasoning and expertise. Okay, in next week's blog, we're going to emerge from the clouds, plant our feet back on the ground and get super practical. Imagine this, a new patient comes in to see you and they've already had 2 pairs of orthoses from another practitioner. What objective tests would you use to determine if those orthoses are actually working? Any suggestions? Well, I've got the leading orthotic experts to answer that very question and come up with the top 5 tests for orthotic efficacy. You can complete all of these tests within your initial examination without expensive diagnostic equipment or time-consuming processes. You're going to love this. Well, maybe not, especially if you discover that those orthoses you thought were good are actually useless. Thanks for watching this video, and thanks for your interest in getting more predictable outcomes for plantar heel pains. It's truly inspiring to be with health practitioners who make it their mission to get the breakthroughs that help more people like never before. Make sure you download the fabulous freebie on the latest orthotic therapy evidence. See you next week for more battle-tested plantar heel pain shortcuts. Ciao.